moving forward, the next presentation today would be by Dr. Prasanta Roy, who is going to tell us about how to prepare a scientific case presentation in psychotherapy.
Yeah, is it visible?
Yes, sir, it's visible. Sir, एक बार screen enlarge कर दीजिए. Presentation. Yeah, it's visible now.
Okay. It's very basic theoretical foundation on how to prepare a case study in psychotherapy that we thought about, because in hypnotherapy, as we are aware that the mainstream therapist, be it medical professional or psychologist, they are not accepting the role of hypnotherapy as such. And there are many people, many scholars, they are doing individual work using hypnotherapy. Unfortunately, we are not designing our work in a way that can be published. So that is one issue. So if we search Google Scholar, hardly from India will find any studies using hypnotherapy as such, be it case study, be it other form of design. So here it is basic orientation, so that the expert, not the expert, the trainees particularly, they can get some direction that how to do the work so that those work can be published. Whether the second slide is visible?
Yes, sir.
Okay. So when we talk about how to do psychotherapy research, there are various design concepts we think about. And one of the most popular the design is single subject experimental design. The single subject experimental design is not about only a single case, but it's a group of case with similar presentation. So it can be a community, or it can be single community of a particular case, or it can be a single case where we can introduce some experimental aspect into the research design, so that we can see if there is any change in the outcome. So whenever we talk about the experimental aspect, that means it has to be measurable. So we need to have a baseline data. We also need to have the outcome data. So these are the measures that we need to have to comment upon whether the experiment that we did, what is the experiment? The psychotherapeutic experiment or the hypnotherapeutic experiment, whatever we did, whether that experiment is able to bring any change in the data, the objective data from baseline to the outcome. Ideally, the single subject experimental designs are framed in ABA format. ABA means A is the baseline where no intervention has been started, and we are doing the measurement of particular exam. For example, we are dealing with anxiety. So we are getting the anxiety score as baseline data, maybe using a particular scale, for example, Beck Anxiety Inventory or Hamilton Anxiety Inventory. With this kind of scale, we are having it before we are implementing the intervention. Then we are going for 4 sessions or 5 sessions of the hypnotherapeutic intervention or other psychotherapeutic intervention. And then after intervention, we are also assessing the score, that is the B phase. After intervention, after the experimentation, whatever the BAI score or Hamilton Anxiety Rating Scale score is, that is the B. So it generally follows our AB design. Though single subject experimental design AB design is not the ideal single subject experimental design. It should be ABA. So that means A was the baseline. Then we did some intervention, and then we are getting the outcome score, that is B. Then there should be a period without intervention. There should be a period without intervention. And again, we are going to assess A, and another outcome, with the expectation that in absence of this intervention, the person should go back to the baseline so that we can really claim the intervention was helpful. However, in pharmacological research, this can be quite helpful. When you are giving some chemical and you are changing if there is any short-term outcome. But in psychotherapy research or hypnotherapy research, it can be an issue because we know we are dealing with the coping skill enhancement, and we assume that there would be long-term impact of the coping skill that is being given to the client. So the ABA cannot be followed in this population. Another experimental design that we thought about, that is counterbalancing design. Counterbalancing design means, for example, there are two interventions. We want to see the efficacy of hypnotherapy in anxiety disorders. We also want to see efficacy of cognitive therapy in anxiety disorder. So there are, for example, 10 subjects who are having anxiety related issue. We have taken the measurement using Dec anxiety inventory, and after taking the measurement, then with one group. So with one group, we are dividing this 10 subject in two groups now. Now 5 in group A and 5 in group 2B. In group A, what we are doing, we are starting with hypnotherapy, 5 sessions of hypnotherapy. Then we are going for, then we are reassessing the client on Dec anxiety inventory. Then we are going for 5 sessions of cognitive behavior therapy. After 5 sessions of cognitive behavior therapy, again we are reassessing the client. So that is with group A. But with group B, what we'll do, after getting the baseline, we'll start with CBT in group B. For 5 sessions of CBT, then we are doing the assessment again, then 5 sessions of hypnotherapy, and then we are doing the assessment again. So that is counterbalancing to see whether the hypnotherapy was more efficacious than CBT or CBT was more efficacious than hypnotherapy, using a counterbalancing mode. So all the subjects are getting same treatment. All the subjects are getting same treatment, initially hypnotherapy or CBT, any one of these two. So that is counterbalancing design, and in psychotherapeutic work, this is still feasible design. However, this AB design is most accepted. Even when you do the single case study design, this AB format is easy to follow. Then comes the repeated measures design. Repeated measures design is same, where A, B, the design we already discussed, and we also add the follow-up to see if there is sustainment of the therapeutic intervention is there or not. So that is A, B, C. That is repeated measures design. Repeated measures design generally we follow for group of sample rather than a single case study, but it again can be followed. Then the randomized control trial is there. It is most accepted form of therapeutic research design, where the group of patients, for example, if I'm having 20 patients with anxiety disorders, these groups would be randomly distributed in two groups. And in one group, we want to see the efficacy of hypnotherapy over cognitive behavior therapy. So one group will get hypnotherapy for a number of sessions, and another group will get CBT for number of sessions. Equal number of sessions should be there. And after having those sessions, then we'll also need to get the outcome score, and we'll compare these both groups, whether there is any difference in the outcome score between these two. That is randomized control trial. In some of the randomized control trial, we may not have the second psychotherapy option. One group will get hypnotherapy, another group will be wait list candidate. So if we believe that the hypnotherapy is going to be helpful for each client, so we will not deprive them, but they will be put under wait list. So if 10 sessions of hypnotherapy was planned, the group A received 10 sessions of hypnotherapy. We got the baseline data and the post-intervention data. Second group, and this 10 sessions probably took 10 weeks. So for this 10 weeks, the second group, either we just had a psychoeducation, or just had a supportive mode of intervention, or just we talked to them, or maybe they were not given any kind of talking experience. So after 10 months, they were again, 10 weeks, they were again assessed, and we'll try to see if there was any difference in score between A and B group, and also the baseline and the outcome score. So this is part of randomized controlled trial. And while we go for this research design, there is concept of single blind or double blind clinical trial. Single blind means the therapist doesn't know the anxiety score. And double blind, not the client, not the therapist know about the outcome that is happening. But in psychotherapy research, we design psychotherapy sessions based on the issues, the problem, the severity of the problem. So it is very difficult to follow at least double blind clinical trial with hypnotherapy or any sort of psychotherapy. And that is one of the biggest criticism that people make against hypnotherapy. They tell, show us any randomized controlled trial with double blind control. We'll not be able to show them. It's very difficult to plan a therapeutic process like this. So these are the common psychotherapeutic research design that we follow. Now, if you look at the steps, I'm going to talk about this AB design. So here, the steps include selecting a case and finding a focus. I need to select a case. And before selecting a case, I need to ask to myself why I'm selecting this case. What kind of contribution this case is going to make in the existing literature. Is it going to provide any new information? Is there something interesting that was not addressed? Or there was a confounding outcome in previous researches, and it is going to be helpful to conclude something. So that's why I'm going to select a particular case. Or I want to experiment with a particular psychotherapeutic aspect that is following a particular theory. And based on that, I am going to see whether that theoretical applications is going to be helpful or not. For example, I want to, a person has come with homosexual conflict. The person thinks that I see that I am having homosexual orientation and to some extent heterosexual orientation too, but I don't want to be in the homosexual orientation. I'm not very comfortable in such cases. And now I am to see whether ego strengthening, hypnotic ego strengthening can be helpful for the individual to make a decision, which one to follow, which one not to follow. So in such situation, the literature search shows that there is no such study that can give any kind of comment on that. Now, why I'm considering the ego strengthening can be helpful to deal with this kind of indecisiveness or ambivalence in an individual. So I need to explain from a theoretical foundation or the literature research review work why I'm selecting this case. And after selection of the case, I need to find the focus. Finding focus means define the targets for change. What are the things I'm expecting to be changed? Okay. And whenever I'm defining the targets for change, I need to measure that target. I need to measure that. I need to either in terms of frequency or in terms of latency, in terms of severity. Severity, we can use a visual analog scale, or sometimes maybe 1 to 10 point scale, or 0 to 100 point subjective unit of distress score. For pain, like 1 to 10 point scale can be helpful, or maybe some scale, rating scales, like for anxiety, Beck anxiety inventory, depression, Beck depression inventory, like this. Then we need to go for case formulation. Case formulation is an important part for psychotherapy. So whenever we are going to present the psychotherapeutic research, the case formulation is mandatory. So how I am conceptualizing this particular case, from which theoretical foundation I am conceptualizing. Like hypnotherapy, if I am planning whether I am going to work on the hypnodynamic work or cognitive hypnotherapy or supportive hypnotherapy or SNL emotive hypnotherapy. So whichever the hypnotherapeutic process that I'm planning, based on that particular uh, theory, I need to formulate the case. I need to formulate the case. Like cognitive behavior therapy, we are pretty aware about like how to make the formulation. So if I'm going for cognitive hypnotherapy, maybe a cognitive behavioral formulation would be helpful to explain the symptomatology of the individual. Uh, if I'm following a eclectic modality, combining CBT, hypnotherapy, sometimes maybe a cognitive formulation might be difficult. So in such cases, we can at least formulate the case based on biopsychosocial model. Then we need to note down intervention narrative, session-wise intervention narrative, particularly would be helpful, so that the other researchers, they are also aware that what was done and that can be replicated. And then the outcome measures, again, we need to get the data of the outcome measure to see if there is any change in the slope. And after getting the outcome measures, we need to interpret the finding. We need to interpret the finding, and we need to discuss the finding, why the particular psychotherapy that we used, why it worked for this particular client or why it didn't work for the particular client. Okay, so that discussion that we need to follow. And finally, we need to summarize our contribution to the clinical knowledge, how it is going to contribute, what are the future directions that we need to think about. So these are the basic steps that we follow. As I said, the rationale for selecting this particular client of the study, that has to be explained. That has to be explained to ourselves. That will motivate the editors of a particular journal to look into this case. Otherwise, they will directly reject that case. And we need to focus on research methodology, which particular design I am following. Single subject experimental design, AB design, or repeated measures design, that we need to mention. And what are the baseline scores? What are the things I am using for the baseline data and outcome data? So that is also part of the research methodology. And we also need to mention which clinical setting the client was treated. What was the frequency of the sessions? Okay. And sources of data concerning the client and treatment process and outcome also need to be mentioned. For example, if we got previous case records, or if there were any informants, or the client himself or herself was the informant. So all those sources we need to mention. So these are some of the process related to the psychotherapy, the research plan. Now I'll share one of the case studies that got published in International Journal of Clinical and Experimental Hypnosis. Is it visible?
Yes. Yes, sir.
Is it? Yeah, it's visible, no? So I'll just highlight some of the components that I mentioned in this particular case study. It was a case study on efficacy of combined cognitive behavior therapy and hypnotherapy in anorexia nervosa. So it was a case study. So in this case study, what are the things that we followed? We had a small discussion on anorexia, very small, very focused discussion on anorexia nervosa, and why a psychotherapeutic case study need to be presented on anorexia nervosa. As we are aware, like I have highlighted, that anorexia nervosa is increasingly becoming a common disorder in adolescents and young adults, though it is not that common yet in country like India. And if you look at the psychotherapeutic work or the pharmacological intervention also, it is considered as difficult to treat, and a number of factors as contributing to this status, why it is difficult to treat. So obviously, so if I can show with a particular psychotherapeutic intervention, these difficult to treat conditions could be held, so obviously it will get some meaning. Okay, so that was the need. Cognitive behavior therapy for eating disorder is a multi-component treatment package, including self-control techniques. We are telling about what are the strategies are generally followed for cognitive behavior therapy, and why I'm considering cognitive behavior therapy for this particular case, and also the role of hypnotherapy in this particular case. Then we are going for a brief case description, very focused case description that includes the sociodemographic data and the clinical data, the duration of the problem, the manifestation, the symptoms manifestation of the problem, all those issues, including what are the intervention that has been already tried, or client is receiving any pharmacological intervention or psychotherapeutic intervention that is going on, and what was the outcome of those interventions. So those three things, those issues I included, and I also mentioned about if there is any family history of psychiatric morbidity, because that can be helpful in formulation of the case. Then I mentioned the intervention planning and its implementation. Okay. So in the intervention planning, we discuss about the assessment also, the cognitive assessment, and here I used eating attitude test, and what was the baseline score, that also has been mentioned in this particular client, and what are the contract that we made with the client so that the psychotherapeutic work can be done, that is also being explained. Then I have given a case formulation based on cognitive behavior therapy model, and that includes what are the predisposing factor, and that those are already given in the history part, and what was the precipitating factor, and then the kind of schema formulation and that we got. Those many of these issues of the case formulation we actually got to know from the intervention itself, not during the history taking. All these issues had been given here. And then the intervention, session-wise intervention has been mentioned, which is rational, and what was the outcome, the descriptive outcome of each of the sessions, those also were mentioned. And finally, the objective outcome after the end of 7 or 8 sessions that we could do with this particular client, the objective outcome on EAT, that is eating attitude test, that is also been given. And we also mentioned about the 3 months follow-up. For this 3 months, she was not under treatment, and also data on 6-month follow-up, so that we can show that this intervention, whether it was continuing even after discontinuation of the treatment process. And finally, we have given a conclusion or the summarization, what might have contributed to the change in this particular client, and what are the future research that we need to think about. So these are some of the basic aspects of psychotherapeutic research. What I am highlighting again and again, that whenever you're planning intervention, get baseline measurement. Get baseline measurement as well as the outcome measurement. These two are necessary. Otherwise, no journal is going to accept it. No standard journal is going to accept it. Second, whenever planning a therapy, from what theoretical foundations I'm planning the particular intervention for this particular client, and why I consider this client is suitable. What is the rationale for it? मन में आया कि ये मुझे आता है इसलिए कर दिया. वही करते हैं हम लोग ज्यादातर, but the general people is not going to listen to it. We need to have, so whenever you do a work, there are two aspects. One is the clinical methodology, and another is research methodology. So clinical methodology में research methodology को डालना है, उसको add करना है, so that we can get a good outcome work, and those works can be published. And if we, though case studies are not very good design of research, however, still it can bring focus. It can bring the focus of the audiences or the readers, can be quite helpful documentation. So that is the thing that I wanted to share. If anybody would want to contribute anything.
Thank you, sir. It was really very useful. And it was, I mean, we really wanted you to conduct this session with us for a very long time. Thank you for taking this session today. Sir, though I have one question, like sometimes client will come uh, and so I want to know what kind of scale can be used. So I recently had a client who complained of feeling um, stuck in his heart, in his chest. And there was some event and he said कि I feel कि कुछ external है जो मेरे chest में आ गया and I feel stuck. So we did a hypnotherapeutic session and वो उसको एक shape दो and अब वो चला गया बाय बाय करके and then it's been 3 weeks and I'm doing regular follow up and he's feeling fine. तो अब जो इस तरह के कोई सिचुएशन आती है तो उसको किस कैटेगरी में डाला जाए या क्या टेस्ट कराया जाए ऐसे में?
See, you are a psychologist. Yeah? So you, whatever the physical manifestation the person is coming with, you need to identify what are the psychological manifestation of the physical experience the client is having. So we need to identify what is going on in your thought. What is going on in your thought? You might get that the person is worrying a lot about it. Okay. Or maybe, and what kind of emotional experience that you are having. Probably person is experiencing anxiety a lot. So worry and anxiety, those can be measured. There are scales, there are tools. Those can be measured. If the person is experiencing panic attack, that also can be measured in terms of frequency of the panic attack, or there are some tools or some scales, inventories are there that can also experience the measure. Measure the experience. So you need to identify the psychological outcome. You need to prick the individual so that they can tell about the psychological manifestation. So that can be helpful.
So
in this case, probably worry, anxiety, this could have been measured.
And anxiety was not the case clearly, but yeah, he was experiencing some panic attack and he was kind of convinced that 3 years back he and his friends did some experiment with calling of spirits or blank chit.
Cannabis, yeah, it's very common, yeah.
Yeah, and since that time he feels that, you know, once every week or something he gets this panic attack and this feeling that he's being attacked and he feels congested in his heart. So this was his thought.
Yeah, so the frequency of panic attack can be one outcome measure, can be one baseline measure. Maybe for last 1 month, how many episodes of panic attack were there. That is one thing. And whenever there is a panic attack, there are associated worries, like pain worry scale. There is a PENN, pain worry scale is there. That is very famous, widely used. There is also scale like anxious thought inventory, a particular design for this kind of manifestation. So those scales can be used to address. Right.
Thank you, sir.
If anybody would like to contribute anything.
Dr. Prasanta, sir.
Yes, sir.
Yeah. Actually, first of all, I want to congratulate you for giving this wonderful presentation. I am very happy you have actually published a case study in the international journal, for which I want to congratulate you on our behalf of our participants. Actually, we know what type of expectations the international journals, in order to publish our paper, what type of expectations they're having. Of course, you have fulfilled all their expectation, and you have published in such a way. Your nice presentation was also there. Sir, actually, I want to ask, this is my doubts. 1 or 2 doubts I have. Say, for example, this baseline measurement, we are giving some kind of measurement. Say, for example, we want to measure the anxiety of the patient, for which we are using a standardized questionnaire in order to measure the anxiety. Then afterwards, we are starting either the CBT intervention or hypnotherapy intervention. That time, after the 10 session, again we are measuring the anxiety. Then after that, after introducing the second intervention, once again, we are going to measure the anxiety. That means 3 times we are going to measure the particular variable. Am I right, sir?
Yeah.
3 times.
It is ideally 3 times
3
because
times.
it will give us the understanding whether the intervention was giving result outcome for the short term or for the relatively long term.
Okay, sir. Sir, actually, during this 10 session, whether we have to say for example, we want to give this hypnotherapy intervention during this 10 session, whether we have to ask our patient to practice self-hypnosis.
Yeah, it's depending on how you are practicing, how you have planned your therapeutic intervention. Yeah.
Okay, sir.
Then self-hypnosis is a coping skill, and if you feel that, so coping skill can be always practiced.
Okay, sir. Then last one is, sir, actually suppose the particular patient is under any kind of psychopharmacological treatment, whether we have to ask the patient to stop that particular psychopharmacological treatment, or we will allow them to continue that.
That is unethical, first of all.
Okay.
That is unethical. So for research, we need to follow all the ethical issues.
Okay.
If we want to do experiment like this, so for single case study, this is not, we are not going to suggest anything.
Okay.
Okay. But if you're planning for a randomized control trial, in such situation, we need to evaluate whether the patients can be considered without medicine. For example, if the person is suffering from anxiety disorders.
Sure.
Okay. Mild to moderate level of anxiety disorders. So if the person is, can be told that whether the person is ready to not to take pharmacological intervention, and if the patient gives consent, written consent, then we can discuss with the concerned psychiatrist and the dose can be tapered out. Only for randomized control trial.
Okay.
And once we get the ethical approval, now if we want to do the same research for client with depression, this might not be allowed because it can increase the severity, and depression and suicidality are quite high.
Exactly.
So that can be risk. So for single case study, we are not going to tell them that you are going to let the medicine be continued. We are not much bothered about improvement is important. We are not much bothered about in the case studies. But okay, during your narratives, you are already telling that, okay, for example, this particular case, who were in pharmacological intervention for 6 months, and there was not much improvement in her status. But within couple of months, there was significant improvement in her status. So that itself can be helpful to pinpoint whether it is helping or not.
Okay.
So there would be some limitations. Let us be with limitation. Let us not to take much risk because it's a health, ultimately health. If there is something is happening, we'll be responsible. So better to avoid that.
Okay, sir. Thank you, sir. Thank you very much, sir. Thank you very much. Yeah.
Sir, I have one question. I was just wondering if we can, for thought disturbance, we use a projective test like Rorschach. And how can we use Rorschach and hypnotherapy or in combination? Is there any possibility some work has been done there?
We can use it. We can use it. We can use it. But for single case study, yes, that can be used to see if it is bringing some change in some of the parameters of Rorschach indices. For example, small m, inanimate movement, that is being associated with worry. So if there is change in the small m responses, so that can be quite helpful. or if the coping deficit index of Rorschach, whether there is change in that score. So Rorschach can be used, but rating scale is more objective. So we may use Rorschach, but